Hello and welcome to the Power of Positive. Thank you for joining us. My name is Charmaine Picado. The show is discussing the lived realities, successes and challenges faced on a day-to-day basis by women and girls living with HIV. We are also going to be discussing how to overcome stigma and discrimination and ensure that women and girls living with HIV have increased access to treatment, care and support, as well as celebrating the heroines of the HIV response movement. This show is brought to you by Bayete Development Institute with the support of UN Women Zimbabwe. Today we're going to be discussing HIV disclosure, mental health and key populations. We have two guests joining us on the show today. Our first guest, Phyllis Mavushi, is a psychologist working with HIVAIDS. Phyllis, welcome to the Power of Positive.
Thank you so much, Charmaine. How are you?
I'm well, and yourself?
I'm doing great.
Okay. Tell us a bit more about yourself. Who is Phyllis?
Okay, I'm Phyllis Mavushi and I'm 26 years old. I was born with HIV and I'm living with HIV. I was diagnosed in 2011 when I was 16 years and I was in high school. I can say as a client, I've been receiving support from my peers who are called community adolescent treatment supporters, who are trained by HIVAIDS and who are trained by Shandiri and the Ministry of Health. So I can say these community adolescent treatment supporters work between the Ministry of Health facilities and also the communities. So I got support from both the health facility and the community where I was staying at. You might want to know about Shandiri, maybe just a brief. It's an organization which supports children, adolescents and young people living with HIV from the ages of 0 to 24. So whilst I received that support, I felt I was hopeless before, and because the issue to do with HIV, it was scary during that time with those myths and misconceptions. But when I received the CAT's support, I became more confident, and I felt it to myself that I need to cascade the same support to my other peers. And in 2016, I was trained to become a community adolescent treatment supporter, offering peer-to-peer support to my other peers. Then I felt, no, I need to do more. That's when I decided, let me pursue this as a career. I studied psychology with MSU. I finished this year in March. And I'm currently working as a psychologist at Shandiri, supporting young mental mothers living with HIV.
Mm-hmm. So when we are talking about HIV, Phyllis, what is disclosure and are there different types of disclosure?
Oh, yeah. Okay, I can say that disclosure, it is an act of revealing information or a secret to someone else. Yeah, and it needs support. It needs one to be prepared for one to be disclosing. I'm going to touch, there are two main forms of disclosure. Disclosing to someone their HIV status and having that person who is HIV positive disclosing their status to others. Or maybe there'll be subtopics under that I'm going to talk of partial disclosure, full disclosure, public disclosure, and also accidental disclosure. So when we are talking of partial disclosure, here it's done to children who are at least 6 years old. We want them to understand that they are living with HIV, and we want to help them to adhere to their treatment. But we are not going to give in the full details. We are going to give them information that is age appropriate, but when we are looking at the developmental stages of children. So maybe we can talk to them and say, no, you have an infection which needs you to be taking these pills daily. If you take them daily, it will help the soldiers that are in your body to fight this infection so that you stay fit, healthy, and strong. And as they grow, we are now adding on to more information so that they fully understand. That's when we go then to the full disclosure. You're giving in the full details. Was it horizontal transmission? Was it vertical transmission? Here we'll be using terms to do with the CD4 cells, the virus itself, HIV itself, and so that they fully understand now and they're able to take their treatment well. When we're looking at public disclosure, this is where it can happen in several ways. I can decide to go on a platform in the community and tell them about my HIV status so that maybe others can get courage and they can, look up to you and get support. You want to share with them your journey that I'm living with HIV, I've overcome this and that. Public disclosure, it also can happen when I'm also disclosing to a partner. This dating thing, I want to tell them about my HIV status, or maybe to family members, I want them to be aware of my HIV status. Then we have accidental disclosure. Now, this is done when they say someone, they don't intend on disclosing their status, or they have disclosed it, but they don't intend the person who is HIV positive to hear what they said. For example, a caregiver may be discussing about their child's HIV status, but they don't intend that the child hears, but accidentally the child is going to hear that, my aunt is discussing with the neighbor about my HIV status. Yeah, so these are the forms of disclosure that I can say. Yeah.
Thank you, Phyllis. So you had started already to talk about when disclosure is required. For example, if it's a child, you want to start administering art. But when, can you expand more? When and where is disclosure required?
Okay. Disclosure, when you're talking of the when, like I mentioned for the child, with we can start at 6 years. Yeah, it can happen anyway in a conducive environment. You can choose to have to disclose the status maybe at a health facility with the support of a healthcare worker. You can actually choose to do it at home, provided it's a conducive environment. There are no people around that are going to be eavesdropping, and it will help whomever you're disclosing to understand.
Mm-hmm. So how does disclosing one's status then affect their interactions or their relationships with family or in the workplace and other spaces within the community?
Okay, I can say it depends. Yeah. Well, we can start with family. So let's say if they were together during the testing process and all, it is actually easier because they would have been given the information by the healthcare worker. But sometimes one may have gone to the health facility alone and they've started the journey of taking their antiretrovirals. They now want to disclose to the family. There can be issues to do with stigma. How did you get infected? You're going to be a bad example to the other family members. Suppose it's a child, a teenager, or a young person. You're going to be a bad example, So there will be a lot of stigma and they'll be discriminated. Let's say maybe if we're looking at, family gatherings, they'll be labeled as those that are unworthy to mingle with others. We're looking also at issues to do even with bad examples. They'll be labeled in their family. When we're looking at the workplace, also one may not be accepted. We look at the culinary fields. If you would want to disclose and, you may face a lot of stigma from my interactions with the other young people because you're directly involved with this business in this cooking and stuff. So you may face a lot of stigma there. Looking at, say the churches, right? Mm-hmm. Yes. We may get support. Depends on the types of the churches. I can't mention names. One may get support, one may be stigmatized. I remember when I was growing up, the church I was going to, we couldn't openly disclose because issues to do with HIV, they were linked to promiscuity. each and every time we had these aunts and asekuru youth and atete youth, they would always give examples of kangoita mskanzo, uchaita AIDS. So that environment was not conducive for us to disclose because we knew automatically we would not be accepted. But however, now we've seen that there is now more support with these churches because of the interventions that are being done by the Ministry of Health and other programs. We have, at Shanti, we also have a component whereby we interact and also partner with the churches and also sensitize my communities, my church leaders on that. No, it is important to support people living with HIV. We also share even key messages around areas to do with support for people living with HIV.
So Phyllis, initially you had started to talk about dating, when you're talking about disclosing your status, you're in a relationship, you want to share, the most intimate parts of your life with your partner. So what are some of the myths and the misconceptions around dating and status disclosure?
Okay. The very first one is it's impossible to be dating someone who is HIV positive and without the one with the negative status being infected later on. People always say, it's better you date for a positive vega or a negative vega. That is one big myth that is around because there are concerns about having to spread the virus to the partner and also to the children.
So I'd want you to talk more now, focus on issues of mental health. I know you're talking about stigma and discrimination, whether it's at church, it's within the family, it's in the community. But what is the relationship between status disclosure and mental health? Are there interventions at addressing this?
Oh yeah, okay. There is a clear relationship between mental health and disclosure. Should I say, I can start off with HIV and disclosure, whereby I want to say that adolescents studies have shown that adolescents living with HIV have more common mental disorders and depression linked to their status as compared to the other children, their peers who are HIV negative. And also, when we're looking at disclosure and mental health, if disclosure is not done properly, it directly affects the mental health of the person, how they feel themselves, how they feel the world around them, how they accept and how they cope. So if partial disclosure is done well up until full disclosure, one may understand and they may develop ways of coping with their HIV status and have a positive mental outcome. But when we're looking at if disclosure is not done properly, there are issues to do with, now we want to tell them that they're living with HIV. There are issues to do with mistrust. Now this child or this person will never trust you because already you've lied to them. And because you lied to them, you have failed to dispel the myths that they've had already. They'll feel shattered. They'll feel crumbled, and they'll be hopeless because of what they've heard. So disclosure should be done properly so that one has a good outcome and maybe, let's say, a way of coping with their positive status.
And when we talk about some of the common mental health challenges that you've alluded to, can you expand a bit? What are these mental health disorders or conditions that you're talking about, and what are the strategies that can be then employed by people living with HIV to cope?
Mostly it's anxiety and depression, prolonged anxiety leading to depression. So the ways to cope, first of all, they just need support. That where they are able to share their fears and concerns about the future, and they can get peer-to-peer support, like the interventions being done by Shandi, whereby they train those community adolescent treatment supporters to support their peers living with HIV on all the issues that are around them. When their issues are, maybe they may need referral, then they can refer to the healthcare worker, so for extra support in order to prevent that. It's normal to feel anxious about the future, but without support, that anxiety can develop into a very huge challenge. That's where we need that support so that they overcome this anxiety.
Thank you very much, Phyllis, for joining us. But before you leave, just lastly, has the HIV response been able to address issues of mental health, particularly for women and girls?
Oh yeah, I can say that we're looking at, looking especially during this pandemic, there have been rise in these issues to do with GBV, you know, and it would affect entirely the mental health aspect of people living with HIV. We also want to look at what has been happening, the issue of, I kind of say forced disclosure, you know, people being stopped at my roadblocks, having checks, the medical records and stuff. So initially, there was a cry, it was just silent, and then there was a cry that, no, this is really affecting us. And now what the Ministry of Health has done, they have actually intensified more support systems to support communities. I can say maybe, for example, we have the issues to do with the multi-month drug dispensing. Clients would have would receive some from 3 months to 6 months supply, so that they don't have to constantly move. Yes, and because it was traumatizing having to disclose your status and all. So I believe that the Ministry of Health has made great effort to support during especially this pandemic.
Okay. Thank you very much, Phyllis, for joining us and you know, responding to some of the questions that we had today on disclosure as well as mental health.
Thank you so much.
Right. Thank you. That has been Phyllis Mavushe, a psychologist with HIVAIDS. Join us in the second segment.
I'm committed to helping women access justice and better health care as a he for she ambassador.
And so, today, I urge you to join me and others to ensure a safe environment for all women.
Welcome back to our second segment. We are joined by our second guest today, who's Annah Sango, a seasoned advocate with vast experience in the women and girls' rights movement, as well as the HIV response movement. Annah, welcome to the Power of Positive.
Thank you, Shemaine.
So who's Annah? Just introduce yourself briefly.
Well, Anna is a mom of two. I'm 34, and I've always been passionate about working with young women and girls, and especially in the area of HIV and AIDS, as well as rights issues and just general empowerment of young women and girls.
So Annah, when we're talking about HIV and key populations, what is the nexus between sexual orientation and HIV?
Well, I think generally sexual orientation is more about how you identify sexually. And then when we look at HIV and AIDS, it's more about a condition. So you would find that the connection would be around how you can be exposed to HIV as an individual, particularly depending on who you decide to be sexually intimate with. So I feel that's where mostly the connection can be, in terms of how you can be vulnerable or exposed to HIV, depending on how you identify sexually.
Mm-hmm. And when we're looking at key populations, especially those that identify as lesbian, gay, bisexual, transgender, intersex, queer, as well as men who have sex with men and women who have sex with women, what are some of the challenges that they are currently experiencing?
There are a lot of challenges. Firstly, in terms of healthcare, we still are very stigmatizing when it comes to offering services, health services to key populations like the ones that you mentioned. And it's very challenging when they also need to access services, because they have also a certain level of internal stigma that they face. And it's more worse when they are HIV positive. They face a whole lot of intersectional stigma that they have, being HIV positive and also identifying as a sex worker, as a lesbian, or as a gay or trans person. So it's very challenging when they need to access services. And also sometimes interventions that we have are not really reaching key groups such as those. And it's also very limiting in terms of information. It's also very limiting in terms of the packaging of the information that they need to have. So there are a number of challenges that we can speak to, but I feel like access to healthcare is a very big challenge, and also tailor-made services for key populations, as well as, tailor-made information that is packaged within a way that they can be able to access. So I think those are, just a few of the challenges that they face.
Mm-hmm. And speaking of identities, there's another key group when we speak of sex workers, and the secrecy around sex work and the forced disclosure when you need access to, whether it's treatment, it's care, or it's support. So can you unpack for us some of the critical issues that come up immediately when we start speaking about sex workers and the HIV response?
So when it comes to sex workers, first, it has been an issue around us branding them as supposedly the people spreading HIV because they are into sex work. And it's all coming from a place of us not understanding the dynamics of that profession. So if you look at HIV and AIDS back in the 90s, 80s, when it started, people would think, if you're HIV positive, probably you got it from a sex worker. So we've never really understood sex workers, and we've always branded them as being the culprits behind HIV and AIDS. But now looking at how information has evolved, as well as HIV and AIDS and work around HIV and AIDS has evolved, we need to understand how they are also very much vulnerable to HIV and AIDS. You'd find it that most sex workers are actually people who constantly and at most times really try and make sure that they are using condoms, because they know the risk that has on their profession and their work and their lives. And you'd find that somebody who might supposedly be married and have a wife and 3 other girlfriends or side chicks on the side might actually not be using condoms. So when you look at those two different people, and then you look at the risk of HIV, you'd find that the risk of HIV is more to that person who's sleeping with 3, 4, 5 people, who's married and not using condoms, rather than a sex worker who's making sure she's using a condom with each and every client. So with that also, and over time, we've never managed to be able to have interventions that are really friendly when it comes to sex workers. But I'm happy to say that, a lot has been changing in different areas, whether it's peer related, whether it's coming from certain institutions or organizations. A lot of work has been put into making sure those subgroups are really catered for and supported, and they're getting the treatment and care they need. Mm-hmm.
And just to take you back to your last point, Anna, can you unpack for us further, some of the solutions that have been brought in within the national HIV response, catering for key populations?
So there has been interventions around mobile health, whereby the intervention is to be at the place where you can get most of these key groups. So it's not only saying they should go to X and Y facility, but they can actually have the mobile facilities come to them. So where they congregate the most, or where they meet the most, or where they are likely to be, that's where the services are. And then you'd also find that when it comes to condoms and other, incentives like lubricants, etc., you'd find them dispersed probably in bars, you'd find them dispersed in workplaces, and other public places where they can actually be able to access them freely. So those are one of the interventions that have been happening. But also there's a lot of awareness raising that has been happening at national level, coming from the community level as well, engaging with different groups and educating them about these different key populations, and also some of the dynamics around how better to support them. So there's a lot of awareness raising that has been happening, and practically there's a lot of mobile health that has been happening as well. This is just among so many other interventions that a lot of key groups and organizations have been doing.
Mm-hmm. And now, Anna, you know, with the nation and the world at large addressing issues of the COVID-19 or challenges brought about by the COVID-19 pandemic, what measures have been put in place to ensure that people living with HIV, in particular key populations, still have access to treatment, care and support? You know, just going back to what you're talking about, mobile services or being able to congregate in places, and that's no longer possible. So what measures have been put in place?
So it's been a very bumpy ride with COVID and, you know, access to services. And I can really speak to issues around, you know, access to antiretrovirals as well as other HIV services. So we've seen a lot of community groups really coming forth to make sure that they support their peers within the communities. So we've always had groups where people kind of, you know, get treatment for each other, known as CAGs and the likes. So a lot of people have been utilizing those services to ensure that, you know, they have one person going to a facility, collecting their treatment for them, and then come in disperse. And then we've also seen, I think when COVID was starting, a lot of interventions and work being done by facilities to make sure before we went into lockdown, everybody had managed to acquire medication that could last them until, you know, the lockdown was over. And then also putting a system in place that could make sure that there was clear follow-up so that they can come back for their reviews and everything like that. And also just checking up on them at home, you know, to manage mental health issues and other challenges that they may be facing. So we saw a national response that really looked at ensuring that people were going into lockdown with the right medications. So now with a bit of flexibility with the lockdown, whereby facilities are open for a certain amount of time, it's also quite easy because people can just walk into the facility within that speculated time and be able to access the medicines.
Mm-hmm. And now with mobility being restricted, even, I'm just coming back to the same question. So now with mobility being restricted and, you know, movement becomes compromised, when we look at key populations, for example, sex workers, what has been the impact of that?
It's had a very bad impact on them. I know of cases where people would kind of be stopped and had to forcibly disclose why and what they wanted to do, why they were going to a facility and what was the reason. So there were a lot of challenges with that. But I think what's best is if there are facilities and they are key, probably peer-led interventions that are happening, it's good to just coordinate those efforts and see how best we can support those subgroups. Because I do believe there are peer groups that are within communities who actually know how to reach, you know, groups of sex workers, groups of, you know, key populations, LGBTI and the likes. So it would be good to just coordinate through that and see how best they can be supported. If there are organizations, for instance, who are particularly working, let's say, with people living with HIV, like ZNP+, everyone knows that probably if they go through that channel, they can be linked to the nearest facility. So that could be coming even from district level. We have organizations like GALS who are working also with the LGBTI community. So you could also be linked through certain organizations like that to other peers that can support and ensure that you get the services within the time that you need them.
And Anna, what would be your call to action to health officials when we're looking at issues of addressing stigma and discrimination that is faced by people living with HIV, as well as key populations that are living with HIV?
I think what's most important is to really invest in interventions that try and address stigma. Like, for instance, we have what is called the People Living with HIV Stigma Index. So this is a study whereby we are actually looking at measuring stigma levels within communities. So it's more of like a questionnaire that looks at different aspects and attributes of life that a person living with HIV can actually be exposed to. So, and after that study has been done, the data is analyzed. And once the data is analyzed, realized, there are recommendations that are made at a national level. And whilst the study is being done, a lot of stakeholders are part of that study. You know, Ministry of Health, faith-based organizations, people living with HIV, and also groups of key populations. So from those recommendations, I think it would be important to also collectively work together to address some of the issues that come out. If there are issues around health service delivery, then we look at those recommendations and invest in addressing those recommendations. But the most important thing is really, you know, having the political will and commitment to really invest in interventions that address stigma, because stigma and discrimination really is a challenge, and it's really driving people to the edge. And especially when you're looking in these COVID times, there's a lot of issues that are happening with stigma and discrimination. So I think it's really investing in making sure that we address stigma. We shouldn't think that because now we can freely talk about HIV and AIDS, stigma is gone. It's not. There's still family stigma, there's still community stigma, workplace stigma. Stigma is just everywhere. So we need to be really attuned to see some of the gaps that we have in our national response in terms of addressing stigma, have really clear policies around, you know, stigma and discrimination and how best we can address it, and really invest, put money into addressing stigma and discrimination.
Thank you very much for joining us and being with us today, Anna. Are there any last words or key message that you'd like to leave with us?
Thank you so much, Charmaine, for having me. I think probably what I can just say is, you know, let's stay safe. Let's try by all means to, you know, stay healthy and keep our loved ones safe as well. And let's just adhere to some of the regulations that are there, such that we, you know, we can be able to live productive lives.
Thank you. Thank you very much for being with us today. That was Anna Sango, our second guest on The Power of Positive. But thank you very much for joining us for today's episode, where we've been talking about HIV, key populations, as well as disclosure. We continue with the message of The Power of Positive, proudly brought to you by Bayete Development Institute with the support of UN Women Zimbabwe. Don't miss the next episode. We continue with this conversation. Goodbye.